start. Okay, guys. Remember, there are four sources for ATP. Always remember that. Four sources of ATP, muscle contraction. First is the steroids, which last only for 4 to 6 seconds. And we have the episode glucose, which is really organized glucose. Here. Okay. See your notes. Sources. I hope you know this. Again, some of these highlighted divisions. And then, okay, here are the sources for ATP. First, storage, but this lasts only for 4 to 6 seconds. Then your direct phosphorylation of ATP by creatine phosphate, so it lasts only for 10 seconds. Then your anaerobic pathway glycolysis, that will last only for 30 to 40 seconds. Okay, then of course, all the rest, every 1 hour, 2 hours, so long as you have oxygen supply as well as glucose, it will last longer. You are now using your aerobic pathway. Aerobic, so it means oxygen. Oxidative phosphorylation. Okay. Remember, your glycolysis happens in your cytoplasm, while your aerobic pathway occurs in the mitochondria. Yeah. Okay. Of course, muscle fatigue. What happens muscle fatigue? Microscopically, there is damage in your sarcoplasmic reticulum, and you know that sarcoplasmic reticulum is a storage of calcium, so you get a calcium imbalance. At the same time, there are other ions that would be imbalanced. Potassium, phosphate, or phosphorus will be also imbalanced. Okay? That is the sort of fatigue or overwork. Oxygen deficit, you know, I told you that for endurance athlete, the moment they reach the finish line, they will just stop. They still run, but slowly. At that because that time they are recovering the oxygen that has been used. Okay? At the same time, after several hours, they take carbohydrates, drinks, to replace also the glycogen, glucose that have been utilized during the event, during the race. So that's what we mean by this. It's the reason why at the end of the race, athlete will be run slowly until they stop and breathe, go on breathing because they want to replace the oxygen that has been utilized during that race. Okay? Remember, when your muscle cramp does not only produce tension or power, it produces heat, fast airspace or output is more on heat than the tension. Tension is 40%, heat is 40% of the output. Now, we go now to the force of muscle factors that will affect the force of contraction. The force is basically the sliding. This is your actin, which are globular lobes, and this is your myosin. They are tabs. That's basically the contraction of what factors affect this, because this is the reason why you are contracting. In other words, force of contraction depends on first bridges or the attachment of actin and myosin, and what are the factors that would affect. Of course, we discussed already the frequency of stimulation, right? That's one. The more frequency, the more attachment. So that's one factor that will affect the force of contraction, frequency. We discussed that already. You have the fused tetanus, you have unfused tetanus. I hope you still remember that. This is the unfused tetanus. Then the fused tetanus would be like that. Here, because the frequency is this one, but here the frequency is very fast. That's why you didn't give enough time for the muscle to contract, how to relax. And it would remain contracted for the whole time. However, if your muscle is undergoing fused tetanus, it would tire easily. Okay? I hope you remember that. So one factor that would affect the force is the frequency. And the next one, of course, the recruitment, right? You still remember? More frequency, greater tension of the muscle, right? So with that, you are pushing a cabinet, it's very heavy. One frequency is not enough, so you have to push and push more frequently. In other words, to push to move the cabinet. And then you have the recruitment, more recruitment. Remember, these are the way to increase. We discussed this already. It's the way to increase the force. Recruitment, greater force. So this again factor that would affect. That's our topic now. Factor to affect the force. And third is the relative size of the fibers. If you are recruiting big fibers, of course, compared to a small fibers, of course, the one that are big fibers would create more tension. So in other words, it will affect also the fibers. If the fibers are hypertrophied, are big, and you are recruiting bigger muscle fiber, hypertrophied cells, you see, of course, it would create more tension. Okay? So the size of the fibers. And of course, later on you will know this. The percent degree of muscle stress. Okay? Muscle stress. So there are 4 factors that would affect the force of contraction. We already discussed frequency, we already discussed recruitment, we have discussed. But we'll go more on the 2 factors, the degree of muscle strength as well as the size of the fibers. Okay? Here you see muscle fiber, more muscle fiber are recruited, more force. Relative size of the fibers, of course, that's self-explanatory, that's logic. If you are recruiting small fibers, you will not make more force. That is greater force compared to a recruitment of big fibers. Of course, more stimulation, you see, more tension. But this one is something that you should know. The length tension relationship, or how many percent will be the shortening. And this is simple. Here are the 4 factors. You see, large muscle fibers, recruitment, that's one that gives you. Now, if you are recruiting big muscle fiber like this, you would expect more tension, more frequency. See, and the percentage of contraction. All of these 3 factors will increase the force of contraction. Now this one is a little bit probably hard to understand, but if you see this, let's say the length of the muscle is 10 inches, okay, 10 inches. Now, what is this 100% will be the 10 inches. In other words, let's 10 inches. The best contraction would be only 8 to 12. Okay, anything below 8, anything above 12, by the way, this is the length of the muscle, will have less tension. See that? Only here. Okay, why? Take a look at the one on the top. You are 100%. This is how many are contacted? 1, 2, 3, 4, 5. Another 5 here is 10. Okay? Now, if you contract it too much, you contract it more, what happened to the active? They would separate the contact between this myosin and active. You end up now with only 4. 1, 2, 3, 4 instead of 5. You can see that? So the more you shorten your muscle by contracting, the lesser will be force. You just figure this out. This blue one, as you contract more, this blue one will go inside, separating the contact of this to the active. So instead of 5 contact, 5 contact here, you end up only with 4. The more you force it to contract, the more it will separate, and the lesser will be the contact. So now, from this picture, you will know that it is not good to contract more the muscle because it doesn't be tension. If you want to contract, it's only 80 to 120% of the length. Okay? At the same time, of course, try to stretch. This is self-explanatory because you stretch, only a few would contact the active myosin. Okay? I hope you can understand. That's why if you apply this, how do you apply this? If you are joining a arm wrestling. See, arm wrestling, it is not good to shorten mats because shorten mats, this is what happened, your tension will be lesser. So if you are here in arm wrestling, the best probably is only this and this. Not too much. See there? Not too strength. There. That's why the best force for arm wrestling is only this and this. If you do it this way, you are lessening the force. Get that? And you know the explanation why. You want on top. Okay? That's what you mean by relationship. So if I ask you to read the test, at what length should the muscle stretch or shorten? Only 80 to 120%. Less than 80, there is now less tension. More than 120, there is now less tension. There. Just remember arm wrestling. Okay. So that's one factor that we discussed. This is now this one. Degree of muscle stretch. Okay? I hope you understand that. But anyway, what's more important then is you should know this between 80 to 120%. Next is the of course the fibers, the more recruitment, stronger. If you are recruiting bigger fibers, stronger. Frequency is this one, we discussed this already. And of course, this is the stretching, which is 80 to 120% only. Okay? Now we go to the velocity and duration of contraction. What are the factors that affect velocity and duration of contraction? Of course, the load. Very simple. If the load is very heavy, your velocity of contraction is very slow, and the duration is very short. It's very heavy. Probably you can only lift that for 5 seconds, but if it's very light, you hit the object for 1 hour, and it's very fast to let the object. So that's self-explanatory for the load. How about the muscle fibers? We will discuss muscle fiber later. We'll go first to the recruitment. The same thing with recruitment. The more recruitment that more motor unit that you recruit, of course you will expect greater velocity, faster, and greater duration of production. But now we go now to the muscle fibers. These two factors are self-explanatory, but we go now to the muscle fibers. There are 3 types of muscle fibers in your body. Of course, they are mixed. It doesn't mean that you only have auxiliary fibers and this person is only glycolytic fibers. These are mixed in the body. But if you are a weightlifter, most likely you have more glycolytic fibers. If you are a endurance athlete, mountain runner, most likely you have more oxidative fibers. But it doesn't mean that all your fibers are oxidative. You have also some glycolytic fibers. So, what are the basis of this classification of muscle fibers? Whether it is fast or slow, it is based on the speed of the enzymes and splitting ATP. The ATP is broken to ATP plus speed to create an energy. The faster the enzyme will split the ATP, the faster will be the fibers. And of course, another factor, whether it is necessitating oxygen or not. You have oxidative fibers, this necessitates oxygen, glycolytic fibers is anaerobic, this does not need oxygen. Okay? So you have here a table, so don't, to make it simple for you, don't bother yourself with the one in the middle. Okay? So just know slow sedative and fast glycolytic. Slow sedative is aerobic pathway. Remember the four sources of energy, storage, direct phosphorylation of ADP, anaerobic pathway, which is glycolytic, and aerobic pathway. So this is oxidative, so this is aerobic, you see, because it is oxygen. This glycolytic pathway is anaerobic. Okay, take note of that. That's probably one. Of course, they are very slow. Of course, they are very fast. What athlete would you associate glycolytic fibers being fast? These are your weightlifters. Okay, powerful movements, intense, or hitting the baseball. What about slow sedative? These are your endurance athlete runners. Okay, since it is oxygen, where do you get the oxygen? From the blood. So you would expect more capillaries for the slow sedative fibers. You would expect less capillaries for glycolytic fibers. Okay? Then, since you have more capillaries, what will be the color of the muscle? It is red because there are more blood. What will be the color of that's glycolytic? Since there is less blood, it will be white. You see? Then of course more mitochondria here. There are also more mitochondria. Probably this one is wrong. This would be more mitochondria also. But you see, since it needs oxygen, you have more content of myoglobin. What is myoglobin? So remember that is the storage of oxygen in your muscle cell. So if you have more myoglobin, what I mean, if your fiber are more of oxidative, those cells of your fiber of your muscle have more myoglobin, you see, and less glycogen store. But here, you should have more glycogen stores. Okay? But anyway, just associate that. Remember, glycolytic pathway. When you are weightlifting, what happened to your muscle? They contract. What happened to the blood vessels? This is the blood vessels. These are embedded within your muscles. Okay, these are your muscles. So when your muscle contract, what happened to the blood vessel? They are compressed, right? So no blood will flow. And there is no supply of oxygen. So where will that muscle gets energy, anaerobic factor, which is no need, you don't need an oxygen. Here, that's why this fast glycolytic has wide tail, less blood. But those aerobic that needs oxygen are red because they have more capillary, more blood. Clear? So don't confuse yourself with the one in the middle. Just these two. You see that? These are endurance athletes. These are powerful, short time, diving, weightlifting, and hitting the baseball. Okay? These are the different type of fibers that will affect force contraction. Okay, this is fast, see it's very short distance. This is slow, accelerating. But this is more powerful, this is higher compared to this one. It's more powerful tension, less tension, but this is slower, greater duration, this is fast. Okay? This is increased velocity, this is increased duration. And load is different. Less load, it's very fast as well as longer for the load. Okay, here is the load. See, greater load, greater latent period, slower contraction, lesser duration of contraction. See, this is exemplified by this graph. This is explanatory. Here, heavy load, you only need probably 10 centimeters, and in a matter of 20 seconds, you are tired. You cannot take it anymore. It's very light. You take it higher, and it will last longer. That's it. Sorry for the load. Improvement, we discussed this already. The more improvement, the more, the faster will be the velocity will be faster, and the duration will be greater duration. Okay, these are adaptation to exercise. If you are a endurance athlete, a marathon runner, what you have to do is the aerobic exercise. And this aerobic means increase oxygen, increase capillaries, increase number of mitochondria, and increase number of myoglobin. So myoglobin is the protein, the cell membrane in your cell, muscle cell that store oxygen. Okay? The end result to endurance. Athlete, endurance, strength, and resistance to fatigue. Endurance are more dependent on oxygen supply. So long as you have oxygen supply, your body has been trained to have more oxygen, you will have more endurance. Okay? How about resistance exercise? This is for the weightlifter. Typically an aerobic, you see, try to contract the muscles just like weightlifter. And what happened? There is no blood supply because the blood vessels are restricted. So the body will utilize the aerobic pathway and result to muscle effect, big muscle size. Okay? We have also here more mitochondria, and here we have more glycogen storage rather than oxygen storage. Here it result to greater size of the muscle and greater strength. Overload principle, of course, this is what we do. If you don't exercise your muscle, the muscle will not become bigger. You have to endure, okay? Forcing muscle to work, promote increased strength and endurance. So, if you want to big muscles, you have to exercise, exert, you have to work. You have to utilize that muscle to work so that that muscle will become bigger. So muscle adapt to increased demand. The more demand that you use, if you are using that muscle, more demand, it will have more bigger size. Muscle must be overloaded to produce gain. If there is no pain, there is no glory. So you have to exercise. Of course, you must have some rest because overuse of muscle result in injuries. Okay? The best program would be alternate aerobic and anaerobic pathway. This is, if you don't use your muscle, it becomes atrophy. So the mobilization per day, it will lessen the strength by 5%. Okay. And without neural stimulation, if you are not using it, atrophy to 1/4 of its initial size. Eventually, if you don't utilize the muscle, you don't exercise, it's all too, it will be replaced by fibrous tissue, not any more muscle, and you end up with fracture. Fracture. That's why in the hospital, you have a patient, let's say a patient is bedridden, okay? You are told to exercise the muscles. Why? Because if you don't exercise the muscle, eventually, let's say this is the knee, the muscle here will become atrophic, and it will be replaced by fibrous tissue. You cannot bend that anymore. That is now contraction. The muscle crossing the joint will become weaker, lesser, and it will be replaced by fibrous tissue, and it will result in contracture. You cannot bend that anymore to straighten it up because the muscle there is already replaced by fibrous tissue. That is the way it contracted as a result of issues atrophy. Okay, so we are done with the skeletal muscles. We'll go to the smooth muscles. Excuse me. You know, smooth muscles, we'll just discuss a few topics about smooth muscle because you will learn this more when you go to the digestive system. Okay, remember, smooth muscles are found in the other organs, especially your blood vessels, your gastrointestinal tract. They are made up of two layers, the outer longitudinal layer and the inner circular layer. As you see here, this is an intestine. These are the microvilli of the intestine, and they are aligned by mucosa. The inner layer is circular. The outer layer is longitudinal along the tubes. The fact is, you are cutting cross-sectionally the longitudinal, that's why this is what you see. However, you are cutting longitudinally the circular muscles. See, this is your smooth muscles. Now, I will just tabulate to you the difference between the smooth muscles and the skeletal muscles, okay? So that it will be easy for you to understand. Okay, skeletal, smooth. Here, what you have, centromere, no centromere, sarcomere. No sarcomere. You have myofibrils. Remember the myofibrils, this is the one that you see numbers if you are exercising. If you have your cell, muscle cell, has only 10 myofibrils. In the cytoplasm, you exercise, it become 20, that cell become bigger. Okay? So here, you don't have no myofibrils. Okay? No T tubules. I'm sorry, T tubules, no T tubules. Here, your sarcoplasmic reticulum are bigger. Here, your sarcoplasmic reticulum are smaller. So, having a big sarcoplasmic reticulum, remember what do you have in sarcoplasmic reticulum? Calcium, storage of calcium. The contraction of skeletal muscle are more dependent on the calcium in the sarcoplasmic reticulum. However, for the smooth muscle contraction, the calcium the contraction are more dependent on the calcium outside not from the sarcoplasmic reticulum, because the sarcoplasmic reticulum are smaller. Okay? And of course, you still remember the epimysium, perimysium, and endomysium. This here in the skeletal muscles, you have the epimysium, that is the covering of the muscle. You have the perimysium, that is the covering of the muscle fascicle, and then you have the endomysium, that is the covering of the muscle fiber or muscle cell. Here you have only endomysium. Okay, you don't have this, you don't have this. Okay, so let me show you that. Okay. See, this is your skeletal muscles. They are striated, smooth or not. They are spherical shaped. They are uninuclear. This one is multinucleated, meaning more nucleus, while here is only uninucleated, one nucleus per cell. Take a look. You have here the epimysium that covers the muscle, the perimysium that covers the muscle fascicle, and the endomysium that covers the cell. But here we have only endomysium. Okay? So here you will see the T-tubules. You have no T-tubules in the smooth muscles. The sarcoplasmic reticulum here, the blue one, are well developed. Here we have less developed, and you depend calcium more from outside. Caviolae are just pockets. I will show you that later on, pockets along this cell membrane that contain calcium. Okay? And of course, you have here what is your nerve and muscle connection, neuromuscular junction, remember? Remember, I told you neuromuscular junction, this is the axon, this is the muscle, and these are the vesicles with acetylcholine, and then acetylcholine is released. So this is neuromuscular junction. But here you have the varicosities. Okay, so you have the varicosities. See, this is one axon. It has several valves. This valve you have the acetylcholine there inside, and each valve supplies each cell. Each smooth muscle cell is supplied by a valve varicosity. So it functions the same as neuromuscular junctions, but the structure is different. So here you will see the acetylcholine that are also released in each of the muscle cell. Okay. And then these are the so-called caviolae. See, the caviolae are some small pockets along the cell membrane, and here you have plenty of calcium. So this smooth muscle will utilize more the calcium in the caviolae rather than the calcium in the sarcoplasmic reticulum. Unlike in skeletal muscles, as I said, the sarcoplasmic reticulum are big and well developed. Most of the calcium in the contraction of skeletal muscle are coming from the sarcoplasmic reticulum, but here, since the sarcoplasmic reticulum are less developed, most of the calcium utilized for contraction of the smooth muscle are coming from the outside, from the caviolae. See the caviolae there, okay? Then of course, another difference is that here you have the C disc. You still remember the C disc? Remember the C disc? This is the myosin. This is the myosin. Myosin. And then this is the actin. Okay. And this is the C disc. One C disc, another C disc is your sarcomere. Just remember that. Okay? Okay. When this contract, the C disc, the tension of the C disc is transported to the cell membrane by your dystrophy. Okay? Still remember when I show you the muscular dystrophy. remember the muscular dystrophy, the baby that the Gower sign? What is the Gower sign? I'll show you. A baby with muscular dystrophy cannot stand right away. Remember, when they are squatting, you told them to stand up. What will they do? You put their hand here. Then you put their hand here. You twist the butt, and then this. That is the Gower sign. This is a sign of muscular dystrophy. Why? What is the problem here? The dystrophy. That's why it is called dystrophy. These are abnormal, so the tension created here is not transmitted to the muscle itself. Okay? Okay, let me see. You are looking at me, it seems that you don't know anymore. Highlighted in the notes. This might be a muscular dystrophy of the genetic disorder that causes progressive weakness of the degenerative skeletal muscle. The word itself, dystrophy, it affects the dystrophy. Curves to see curves. This is the time. Curves to see muscular dystrophy. See that? Paralysis of the muscle because of that weakness because their dystrophy is very abnormal. And I show you the Gower signs. Patient with muscular dystrophy cannot stand up right away. They stand up, they put their hands to the floor, then they elevate their butt, then they put their hand to the knee. That's how they stand. Okay? So a kid following that Gower sign is a sign of muscular dystrophy. Okay. So, okay, here is the C disc. Here, and smooth muscle is replaced by the dense bodies. Dense body will represent the C disc. Okay? So just remember this table. That will be enough for you to know about the smooth muscles. You will learn that more in your digestive system. So first you have your neuromuscular junction, but here in smooth muscle instead of neuromuscular junction, you have paracausitis. There is no sarcomere in smooth muscle. There is no myofibrils. There is no ticubules. Sarcoplasmic reticulum are well developed, big. Sarcoplasmic reticulum are small, such that because of this, muscle contraction are more coming from the sarcoplasmic reticulum. Muscle contraction of the smooth muscle are more coming from outside, not from sarcoplasmic reticulum, specifically the capiolae. See the capiolae? These are the pockets along. In that small pocket, you have accumulation of your calcium there. Okay? I think that's enough for you to know about it. Oh, one more thing. Instead of troponin and the what is this is contractile muscle, here is the sarcoplasmic reticulum, which is very small, and here is the outside calcium. That's why this muscle utilize more calcium from outside rather from the storage sarcoplasmic reticulum. So instead of your troponin, what do you have in smooth muscle? Calmodulin. Another difference here. So put here skeletal muscle. You still remember the troponin? That is where your calcium is attached to. Here you have calmodulin. Okay? So these are the difference between smooth and skeletal muscle. It is from the capital, and that would be enough. We know about this. skip this anymore. We're gonna discuss this anymore. We'll learn this more on the digestive system. Digestive system. Okay, we go to the next chapter now. This is your muscular system. It's almost the same as in the laboratory. Just like in your skeletal system, but more detailed. Remember, the laboratory are only those that are seen in the cadaver. These are the external muscles, but in the lecture, this will be more detailed because it includes your muscle internally. So let's go to number 10 now, chapter 10. Okay, muscular system, you see, muscle tissue, you have three types of muscles, we discussed that. Cardiac, it's related to the heart, the stroke, we just discussed. The skeletal, skeletal in the sense, it's called skeletal because it's connected to the muscle, to the bones. Of course, only muscle function for movements. Okay? Muscle can only move. Now, there are types of muscle that are called agonists, and the opposite is antagonist. It's like if you flex your forearm. What happens? Your agonist is your bicep. Your antagonist that relaxes is your tricep. Or if you extend your arm, your elbow, your agonist now is your tricep that contract. Your bicep now, which is anterior, would be the antagonist because it relaxes. So that's what you mean by. So you have a muscle, could be an agonist, could be antagonist. Just like your bicep, you flex your hand, that is agonist, your bicep is agonist. But if you extend the hand, your bicep is antagonist. Okay? Then you have the synergists. Synergists are muscles that some sort of reduce unnecessary movements of the joints. Okay? Let's say just like your bicep. I will show you your bicep. The bicep crosses two joints. You see that? Okay? This is your scapula. This is your humerus. Remember your glenoid cavity, head of the humerus. And this is your radius, ulna. So your bicep has two origins, that's why it's bicep. One of the origin bicep is coming from the scapula. So if this is the bicep coming from the scapula, it crosses two joints, the shoulder joint and the elbow joint. Now, if you don't have fixators or synergists in this area, what happens if this contract? You are dislocating your shoulder joint as well as your elbow joint. If you dislocate, right? If you don't have a muscle. So there are some muscles here and here to stabilize the joint when you contract your bicep. So these muscles are called synergists. If these muscles, these synergist muscles are fixing, they are called fixator. Later on, you will know the rotator cuff muscles, they are there to fix the shoulder joint, such that if you move this will not dislocate. At the same time, your elbow joint, there are so many muscles that fixators, so that when you contract your bicep, this will not dislocate. So that's what you mean by that. Some muscles that are synergists that would help the prime mover, the agonist, add extra force and reduce unnecessary movement. As I've said, if there is no muscle here, there is no muscle here, the moment you contract this tendency for the humerus is to be displaced. At the same time, tendency of the radius is to be displaced. They are not anymore in the joint. So this is prevented by the fixators. Okay? That's what we mean by fixators and synergists. Now here, let me just show you this so that you will know what are the flexors, what are the adductors, what are the abductors, see. Any muscle that crosses the anterior side of the joint are flexors. Remember, anterior, flex. Any muscle that crosses the posterior side of the joint are extensors. Any muscle that crosses the lateral side, just like the deltoid, passing to the lateral side of the shoulder joint are abductors, moving away. Any muscle that crosses the joint in the medial side, just like teres major, this is the medial side of the joint, are adductors. That is another way of knowing whether this muscle is flexor, extensor, abductors, adductors. Okay. See again, right over when a muscle moves, one will act as agonist, while the other one will act as antagonist. And some muscles will be there to fix or synergist. Many synergists, they are there to help to prevent dislocation of the bones. Okay? How do you name muscles? Location, remember? What we have discussed in the laboratory, temporalis. But one of the chewing muscles, they are found in your temporal bone. So it is named by location. You see? Muscle shape, deltoid is triangle. Okay? Muscle size, minimus, maximus, medius, longus. You have your gluteus maximus, gluteus minimus, gluteus medius. Those muscles controlling your fingers are long, they are called longus. And you can also name muscle by direction of the fibers. Remember, in the abdomen, we discussed in the laboratory rectus abdominis. I told you rectus means straight. This is the one with three tendinous intersections that resulted to your six-pack. Okay. Rectus. When you say the other one is transversus, of course, transverse, oblique. The pattern of the muscle fascicle is oblique. You have the external oblique. So remember in the laboratory, external oblique is at the muscle of your abdomen. Then other origins, tricep has three origins, tricep has two. Locations. Okay? Location of attachment. Then according to the point of origin and insertion. Sternocleidomastoid. Remember sternocleidomastoid? What is the clinical significance of sternocleidomastoid? Remember I told you, the one here, your rhinic or torticollis, the pain in your neck. So that is named by attachment. Sternocleido, clado means clavicle, so it is originating from the joint of the sternum in clavicle, sternocleidomastoid. So it is connected to the mastoid bone, the temporal bone. You have your hyoglossus, starting from the high bone and inserted to the tongue. You see? So these are muscles named by direction of attachment. Then of course action, if it is flexor, extensor, but there are some muscles that are named based on the different types of naming. Just like one of the muscles in your fingers. Extensor, so it is extending. Carpi, it is location. This is function or action. This is location, carpi, meaning carpus, your wrist, your carpal bones. Radialis, the radius. Longus, the shape. You see? That's how you make muscles. Okay, lever system. Try to offers the arrangement of fascicles. You know, depending on the arrangement of fascicle, you will know whether this muscle closes, this muscle is powerful, this muscle is very long or shorter, more shortening. Depends on the fascicles. So you have the circular. Okay. Of course, if you have a circular muscle, you know this function, most likely the function is closing something. Convergent from these origins, you see several origins, the longer origin is only one point of insertion, so this is convergent from many to less to one point. This is a very small muscle. This is your pecs, pectoralis major. Or fusiform is like this. They are not that strong. Fusiform, I'm sorry, convergent, fusiform, parallel. Parallel are very long. This is a weak muscle in terms of tension, but they have the greatest shortening. This one will only shorten a few shortening, but this one will be a greater shortening, but very weak muscle. In other words, you can determine or you can say whether this muscle is stronger or not, depending on the fascicles or arrangement of the fascicles, pattern of fascicles. See? And this would be pinnate means feather, you know. Unipinnate, half of the feather, see that? This one is bipinnate, this one is polypinnate. We expect this to be stronger compared to the unipinnate. See? Okay. In other words, you can determine the functions or the strength of the muscle depending on their arrangement or pattern of the fascicles. Okay, see? Long fibers, more parallel to long axis, but shorten more, but less power. See? Power depends on number of muscle fibers, pinnate or pinnate, stronger tension rather than your pinnate. Okay, another factor that would affect the force of contraction here, the force of muscle. Traction is the lever system. See, I hope you remember the lever, the effort, and the load. Okay, if you have a big stone, see, you want to lift the big stone. Let's say it is 20 kilos. You can lift that even if you have 10 kilos. All you have to do is put a bar, put room, you only apply 10 kilos, and you lift. That is your lever system. Okay? So this is your load, this is your effort, this is your fulcrum. But if you move the fulcrum here, you have to increase your force, probably of 20 or 30 to lift that 20 kilos. Now, if the fulcrum is close to the load, that is mechanical advantage. Why? You only exert 10 to lift 20. In that case, the fulcrum is closer to the load compared to the distance, to the effort. Now, if the fulcrum is close to the effort, that is mechanical disadvantage. Why? To lift 20 kilos, probably you need 40 kilos. That is logical. Okay? That's what we mean by. So anything is a mechanical advantage. It's a power lever because you can load, you can lift a heavy object, but mechanical advantage, you cannot lift the heavy object, you have to exert more than the weight of the object. Now this is your fulcrum, you see, this is the application of your one that you see for your lifting the car. If you are taking a flat, see, this is the fulcrum, this is the effort, this is the load. Even if you want to exert less power, you can make a car that's very heavy. Okay? That is a first class level because the fulcrum is the middle. Okay, this is the first class level. Okay, this is mechanical advantage. You see, you have 10 kilos, you can lift 1,000 kilos. But this one is mechanical disadvantage because your effort is so close to the fulcrum compared to the load. You exert 100 kilos and yet you can lift 50 kilos. That is mechanical disadvantage. That's here. Okay. You have the different class of lever. You have the first class lever, it's like the seesaw. The fulcrum is in the middle. You see that? Now here, whether it is disadvantage advantage or advantage depends on the location of the fulcrum. Fulcrum is close to the load, that is mechanical advantage. The fulcrum is close to the effort, that is mechanical disadvantage. You have a scissor, an example. Scissor, happen to the scissor, it's like this. Scissor handle, and this one is longer because you only exert very small effort and the paper is cut. How about this one? This is a forceps that you use. The needle forceps is very strong because when you are doing a suture, you make sure that you move the needle because it might be misplaced in the abdomen and you cannot find that metal. So the exert here is less, but the grip to the needle is very strong. Okay, that is mechanical advantage. So this is the first class lever. Fulcrum is the midline and it's sanctified by your sternocleidomastoid. The fulcrum is your atlanto occipital joint for cervical and the occipital bone. The weight is your head, and this is mechanical advantage. Okay. Your sternocleidomastoid can elevate or extend your head, which is heavier than the head. Second class lever is the wheelbarrow. Still, this is mechanical advantage because the effort is longer than the load. But again, it's simplified by your gastrocnemius, the muscle of your legs, the weight of your body will be the load. The fulcrum will be the tip of your foot, and the effort will be by your gastrocnemius muscles. The third class lever is, you see this one, the effort is too close to the load. Mechanical disadvantage. See, the effort is close to the fulcrum compared to the load. You exert more effort than the weight of the load. But take note, most of your body muscles are third class level. See, they are not first or second, they are mainly third class level. This one, however, would have more distance or travel of the load, being a mechanical disadvantage, but it has also an advantage in moving. In other words, it moves the load harder. Okay, it's simplified by your biceps. Your fulcrum is your elbow joint. The bicep is close to the fulcrum, not the load. It exerts 10 kilos. You can only weight. You can only probably 5 or 2 kilos, but however, this can be thrown farther. It's like the baseball, the ball in baseball that used to throw it, and it's no farther because the ball is very light compared to your effort. Okay? Again, there are 600 muscles in the body. Now, as I've said, in our skeletal system, we only learn the identification, insertion, origin, and the action. You don't need to know the innervation, likewise the muscle supply, the blood supply of the muscle stones. You only need the insertion, origin, as well as the action. Okay? Okay, again, we are now in the muscular system. This is your back. See the trapezius there. Okay, we start with the muscle of your facial expression. Okay. Remember, in the laboratory, this is your occipital frontalis, this is your occipital belly, this is your frontal belly, and the insertion in origin. Occipital belly, starting with the occipital bone, inserted in the aponeurosis, frontal belly, aponeurosis, to the frontal bone. There. Okay. Now, before that, I will just show you a muscle of the facial expression is a different type of muscles. Why? They are inserted not in the bones. Almost all of the facial muscle are inserted under the skin. such that when they contract, you create some form of facial expression. Okay? Remember, there is such thing as nonverbal communication. If you say something, if you are angry, you can just show your face as anger. It is just contraction of your facial muscle. If you are smiling, even if you don't say, I welcome you, I'm happy, if you are smiling, it means you're happy. You're welcoming somebody. But you didn't say any word. So these are non-verbal communication. At times they are more effective way of transmitting messages than verbal. Okay? So here, why is it so? Because the facial muscles are not inserted to the bones. They are inserted under the skin. So when they contract, you have some form of facial expression. That's what you should know about facial expression. You see, inserted under the skin. They are very important and non-verbal communication. And again, take note that all the facial muscles are supplied. This is the only thing that you should know is supplied with facial muscles. They are supplied by cranial nerve 7, except for one, which I will mention later. Okay? Okay, again, we have bradycardia, erotica, or aponeurosis, the frontal belly, and the occipital belly. Probably in this part, if you have your notes, I told you to bring your notes always, I will just highlight to you the important muscle that you should know. Okay? Let me show you your you have your muscular system. You bring out your muscular system. Okay, these are the generalities, and we go now to the musculofacial expression. Okay, take a look. Now I am guiding you to study musculofacial expression, origin in bone or fascia, inserted under the skin, are innervated by cranial number 7, except, I will tell you later what is the except. Okay? Muscle of the scalp, you see, you have the occipital belly and frontal belly. I really put here, as I mentioned in your laboratory, responsible for horizontal crawling. So take note of that. I would rather tell you what to highlight. Okay, so highlight this frontal belly. Okay, highlight this also. Muscle of expression, inserted in the skin, origin from the bone, innervated by cranial nerve 7. After that, only the frontal belly. See? Okay, muscle of the face, corrugator superciliary is important. Highlight because it is responsible for vertical frowning. Okay? Next, zygomatic major, highlight. It is the smiling muscles. Then, oscillator. Those that I did not mention, you don't need to highlight. Okay? Those are only for reference. These are the things that you should study. So, oscillator, your flowing, sucking, or specific muscles. Probably you can include risorius. Because this is the muscle that moves your angle of the mouth laterally. Okay? Then, orbicularis oculi. Orbicularis oculi, so these are eyes. Okay. This is the only muscle in the face that is not supplied by cranial nerve 7. It is supplied by cranial nerve 3. Levator, palpebral, superioris. This is a muscle that elevates your upper eyelids. Okay? That's why it's levator, meaning it elevates. Palpebral means eyelids. Superioris means the upper. And I ask you, what is the muscle in the face that is not innervated? The only muscle in the face not innervated by cranial nerve 7 is the levator. Just remember, you want to elevate the upper eyelids. So from that idea, you will know the name. Levator is elevate, palpebra is eyelids, superioris upper. Because this is supplied by cranial nerve. It is not supplied by cranial nerve 7. What nerve supplies it? Cranial nerve 3. Okay? Let me show you this. The elevator palpebrae superioris. It is not, of course, seen here. It is something that elevate your upper eyelids. Better picture in that. Just shown in the picture. Okay, this one. Elevator palpebrae superioris. It elevate your upper eyelids. This one you learn this in the 5 to 3 course. These are the muscles that push your eyeballs, the extraocular muscles. Okay, the one with the arrow, that is the elevator palpebrae superioris. Is inserted in the upper eyelids. It's originated from the orbit. Inserted in the upper eyelids, called elevator palpebrae superioris. There, it is the only muscle in the face that is supplied by cranial nerve 7. This is supplied by cranial nerve 3. Okay, let's go back. Got here now. Okay, innervated by cranial nerve 3. Of course, you have to underline, highlight orbicularis oris because it is a kissing muscle. This thing should be made. Although you can also use orbicularis oris for this thing, but it is mainly the posterior. Of course, platysma, I told you that. Tense the skin of the neck, you are shaving. Okay? Highlight that. Muscle of mastication, you have your masseter and temporalis. Take note of that. Probably you disregard the pterygoids. Okay? These are the muscle, the small muscle that goes your jaw, right and left. Okay? Here I also mentioned the posinator, aside from the whistling, sucking and blowing, they are used to press food towards the teeth and in between the teeth. Okay? Probably you can include the sphenomandibular because this is the smallest muscle. Other, that's the smallest muscle in the body, sphenomandibular. Let me show you that. So for here. Anyway, that's the smallest muscle. Somewhere here, sphenomandibular. With sphenomandibular. Okay, so you know now what I have highlighted. Okay, muscle of the tongue, probably you don't need to know except that they are innervated by cranial number 12. That's it. Okay. Anterior neck. I told you, you can divide the muscle anterior in the neck to those that are above the hyoid bone, those that are below the hyoid bone. One is in the lung, known in digastric, it's to belly, posterior belly, highlight that, and the myelohyoid, because it serves purpose as the floor of the oral cavity. The myelohyoid is the floor of oral cavity. Okay, now infrahyoid, meaning below the hyoid bone. I told you the omohyoid, sternum, inferior, highlight that, and probably sternohyoid. Sternohyoid is very easy, from the sternum to the hyoid. Okay? Next, we go now to the lateral neck. Sternocleidomastoid, highlight. What is the clinical significance here? I told you that is the torticollis or rhinic. Scalene muscle, probably I would include scalene muscles. These are your scalene. This one, see, it's your sternocleidomastoid, scalene muscles, inferior, posterior, inferior scalene. Why is it important? Because you will utilize that in respiratory system. That's one of the muscles that will contract if you are breathing forcefully or with force. Okay? You will learn this in your respiratory system. So the scalene, the sternocleidomastoid, the scalene. Okay, so here is scalene muscles, and like that. Of course, the only muscle I told you to know at the back of your neck, splenius capitis. Highlight these three muscles. Okay? Now, the muscle of the trunk, probably I will just review this electrospinate, which are made up of iliopsoas, lentissimus, nalis, lentissimus, mediastinalis. Set. Okay. Muscle of the trunk, thorax, respiratory muscle, you should know this. External intercostal, and diaphragm. Take note, the diaphragm has three hiatus or holes. The hole for the superior inferior vena cava, that bore a hole because this abdomen passes across the diaphragm at the level of T8, it is thoracic ventricle number 8, the esophagus will pass the diaphragm at the level of thoracic ventricle number 10, and aorta number 12. And diaphragm is considered the muscle of respiration, the main muscle of respiration, and it is supplied by pericardium. Okay? Okay, let me just show you that before we speech. So let's take the other. Number 10, and then before we discuss this before we speech. Okay? Okay, here is your external oblique, external intercostal, and internal intercostal. They have the same pattern like the external oblique of your abdomen. If the external oblique is V-shaped, external intercostal is also V-shaped. If your internal intercostal is A-shaped, your internal oblique is A-shaped, your internal intercostal is V-shaped. And this is your diaphragm, you see? It has three holes. Make sure you know these three holes. Okay? So you have to highlight this. Okay. We'll see each other next week.